Now, if you talk about the guidelines, almost all the guidelines except the NICE says that you have to get a blood sugar, you have to screen for GDM right at the first antenatal visit. So that is what is done here in India. And then because the baby is big, birth trauma can be there. Later on, the patient baby can have hypoglycemia, and because of the trauma and the big baby, hyperbilirubinemia can be there, and RDS can be there. This is the MIG tofu trial with almost 750 GDM females, where insulin versus insulin plus metformin was compared. Neonatal outcome were not different. Hypos were lower in metformin. If you talk about elderly with something having limited life expectancy, who is frail, the target is 8. Up to 8 is okay, we are okay. But if you can achieve a lesser HbA1c without significant hypoglycemia, then you should target it lower.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Good evening, everyone. Thank you for tuning in, logging in, sparing your valuable time to listen to me. Today's talk is very important one. That's diabetes management in special situations. So what we'll be talking about is pregnancy, then elderly, and then in hospitalized patients. So everything is really important in clinical practice. So no financial disclosure to report for this presentation. Diabetes management in pregnancy. Let's start with pregnancy. So what is GDM? Gestational diabetes mellitus. So if you see the definition, it is condition with onset or recognition first time during pregnancy, which is not overt diabetes. So let us discuss one each and every one here. So onset or recognition during first time during the pregnancy, that means the patient is not already known diabetic, not on treatment, and first time during pregnancy you have diagnosed that the patient is having higher blood glucose, is having hyperglycemia, which is not over diabetes, right? So over diabetes is when the fasting is more than 126 and your 2-hour plasma glucose is more than 200. So that is the upper limit where you will call it as GDM. Otherwise it would be diabetes in pregnancy, or let us say at first time during pregnancy you have an HbA1c of 13, right? So that's not GDM. What you're dealing is an undiagnosed diabetes which is presenting first time during pregnancy. So that is the difference, right? Now if you talk about the guidelines, almost all the guidelines except the NICE says that you have to get a blood sugar, you have to screen for GDM right at the first antenatal visit. So that is what is done here in India. So almost universal screening is opted by all the guidelines to see hyperglycemia in pregnancy. So when should we screen? We should be screening at 24 to 28 weeks. Again, if let's say at first time the sugars are normal, then again at 24 to 28 weeks the screening should be done, and then again one more time screening should be done if the patient has polyhydramnios or macrosomia. Okay, right? Like if you have GDM right at the first, then it's not a screening, you would be treating the patient, then again screening is not there, right? Now let us discuss what is the difference between your DIP, diabetes in pregnancy, and what is the difference between GDM. So both are hyperglycemia as the name suggests, but diabetes is in pregnancy is when you have diagnosed a diabetes first time in pregnancy. It may be diagnosed earlier or during pregnancy, and it may be even over the cutoff of your GDM, right? So that is your diabetes in pregnancy, whereas GDM has a strict cutoff. We are coming to that. Now let us talk about some pathophysiology basis of this GDM. So there are some risk factors like obesity, ethnicity, nutrition, physical activity, genetic predisposition, which leads to increase in glucose, triglyceride, FFA, which leads to maternal insulin resistance, which leads to your GDM. And then there can be maternal and neonatal complications like your preeclampsia and your different obstetric intervention may be required. From the neonatal point of view, stillbirth, malformation, LGA baby, preterm, and then because the baby is big, birth trauma can be there. Later on, the patient baby can have hypoglycemia, and because of the trauma and the big baby, hyperbilirubinemia can be there, and RDS can be there. So all those can be a short-term complication from point of view of maternal or neonatal complication, and long term again the baby can have diabetes, dysglycemia, cardiovascular risk. All those can be happening in long term. Okay, the pathophysiology is basically it is insulin resistance, which leads to increased glucose level, which crosses the placenta, goes to the fetus, causes more of insulin release, more of pancreatic production of insulin, which later on can lead to hypoglycemia, neonatal hypoglycemia, right? That is what is happening here. Now let us talk about your diagnostic criteria. So kindly take a picture of this, take a screenshot of this, because this is slightly confusing and you have to read it multiple times to understand this. So there are n number of guidelines and the cutoffs are totally different. Let us discuss first the very easy one, that is what is done by the DIPSI here in India. So very easy. It's you get a pregnant female, even in non-fasting, you give them 75 gram of glucose, anhydrous glucose, and then if 2 hours blood sugar is more than 140, you label that this is GDM and you start treatment. If that is less than that, it is normal. Very, very simple. Now let us talk about the IAD PSGA, that is the most common thing, and then the WHO and FIGO, all those say same. Here they do what is one step test. The test is to be done in fasting with 75 gram of anhydrous glucose, and you have to check the blood sugar thrice. That is at 0 hour, that is in fasting, 1 hour, 2 hour. So if any of those value is abnormal, one value abnormal will qualify the patient to have GDM, right? And obviously it should be lesser than your overt diabetes. So let us say if 2 hours is more than 200 or even the fasting is more than 126, it is not GDM. So 92, 180, 153, and any one value abnormal, you will label this as GDM. And then let us talk about the ACOG. So American College of Gynecology, here the guideline is for two-step test. So first step is with 50 grams of glucose, and then after 2 hours, if the blood sugars are more than 130, 140, then the second step is to be done, and that is not with 75 gram, that is with 100 gram of anhydrous glucose, again in fasting state. And then here you do what is 0, 1, 2, 3, that is 4-point testing, and any two abnormal will qualify the patient as diabetic. So 95, 180, 155, and 140, these are the cutoff. And your ADA, this recommends that either you can go with your one-step test, which I have already described, or you can go like your ACOG two-step test. Both is okay. But usually what we do is one-step test with 75 gram of anhydrous glucose, and the cutoff are 92 at fasting, 1 hour is 180, and 2 hour is 150. Any one abnormal will qualify the patient as GDM. So screening, if you talk, universal screening is recommended except by the UK NICE guideline. Screening usually it is one step. ACOG recommends two step. Otherwise, ADA accepts both one and two step. Usually it is fasting, but in few of the tests it can be non-fasting as well. Mostly it is 75 gram, but in two step you go with first step as 50 gram, and in the second step you go as 100 gram. And then number of samples required or number of abnormal samples required to diagnose will depend on what guideline you're following. It can be 1, 2, anything, right? 3. So threshold for diagnosis depends on how which guideline you are following. Now, whether 75 gram anhydrous glucose is actually what you do. So this is taken from Amazon, and most of the lab are using this Glucon D. So Glucon D, when you give 75 gram, it is not 75 gram anhydrous glucose. So you read the label here. I am enlarging for you. 100 gram. This has 90 grams of carbohydrates, right? So it's not that when you measure 75, actually most of the lab don't measure, but that is what it should be done. But even if you are measuring like with a weighing scale 75, it is not 75. So a correction factor of 1.1 is done. So for 75, you have to give 82.5 gram of glucon D, which will be equivalent to 75 gram of anhydrous glucose. The targets in pregnancy, kindly take a click of this slide also. This is important. Most go wrong here also. So pre-meal, whether you talk about fasting, whether you talk about before lunch, before dinner, the targets are less than 95, and then 1 hour is less than 140, 2 hour is less than 120. And if you are applying CGM, the TIR in type 1 pregnancy should be more than 70, and type 2 and GDM, we don't have much data, so we go as high as possible. But what is important is that usually TIR, what you take is like not 63 to 140. For pregnancy it is 63 to 140. Okay, so that is a difference here. So 80 is what the lower range you can reach on your CGM, but 63 is what is recommended, right? So 63 to 140 is what TIR you will be taking, right? It's same here because these are the targets, right? Now let us talk about the management for this GDM, or even let us talk about the diabetes management in pregnancy. So mostly, most important is again MNT, exercise, if that's not contraindicated by your OBG. So if the placenta is low lying, maybe exercise would, some type of exercise would be contraindicated. And then let us talk about oral therapy, especially metformin against insulin. Obviously insulin is pretty safe. And then let us talk about monitoring and fetal surveillance. So MNT, usually protein 30%, fat 30%, and carb 50%, what we recommend. But what amount of calorie, that will depend on the pre-pregnancy BMI and whether the baby is like a single pregnancy is there or there are twins. So depending on that, the calorie intake will change. So this is for a single baby. And if your BMI is okay, that is somewhere less than 25, above 18, 30 to 35 kilocalorie per kg per day with this proportion is what is recommended. So that's general guideline you should be remembering. Now metformin and insulin both are category B drug, so we don't have much data, right? No well controlled RCTs, so that's again a slightly controversial. This makes both the drugs controversial, metformin even more controversial. But both are non-teratogenic, safe during IV pregnancy. Earlier guidelines have approved your glibenclamide and metformin, but the newer guideline and including the ADA don't recommend these drugs. So if you talk about metformin, we have meta-analysis that it reduces the risk of preeclampsia, it reduces the risk of LGA baby, and it may increase the risk of SGA, small for gestational age baby. But again, there are different meta-analysis. Some meta-analysis don't uh, show that it reduces or increases your LGA or SGA baby. But overall, the congenital malformation is not increased, and there is no role in prevention of GDM. There is role, some role in treatment, but no role, like you cannot give before, say, a obese female, you can start metformin that later on the patient does not develop GDM. It's not like that, right? Less pregnancy weight is there, less of hypos as compared to insulin, and when you're giving with insulin, again less of hypos because the dose of insulin is reduced, right? Less risk of neonatal hypoglycemia, and patient acceptability is better, but higher failure rates. Many of the patient will not reach the target what you want in pregnancy. This is the MIG tofu trial with almost 750 GDM females, where insulin versus insulin plus metformin was compared. Neonatal outcome were not different. Hypos were lower in metformin. Preterm birth was higher in metformin, but some of the meta-analysis have shown that it may be lesser or it may not even affect. So we have meta-analysis for both. It depends on what input, what data you are taking. But long-term data, if you talk about, we have data of 10 years also. There the children who were exposed for metformin, they were having obesity, they were larger, right? So maybe the baby at delivery is smaller, but they have more rapid weight gain. But again, the data is not that much, right? Scarce data is there. Now insulin, if you talk about, there are short acting, long acting insulin. The short acting is insulin, lispro aspart regular insulin is approved in the Long-acting NPH and Detimir is approved, and recently your Degludec is also approved. Glargine can be continued, but do not initiate. The macrosomia is slightly higher with Glargine, but if the patient is already on Glargine, you can continue. It is pretty safe to give. Okay, both U100 and U300 you can give. Now there is a special thing here in pregnancy. Many of the patient, especially when reaching terms, require steroids so that the baby gets matured, do not have the lung defect, right? So there the sugar increases, right? So you have to increase the basal by 30% and correction doses depending on the sugar you have to prescribe. HbA1c in pregnancy is fallacious because of the hemodilution, but ANC measurement, if it is not there, you have to repeat within 4 to 6 weeks. And one first and second trimester, we have data that it is associated with fetal loss and malformation, higher HbA1c, but again, it can be very fallacious during pregnancy. So you have to be very cautious while taking these report into consideration. Fetal monitoring in GDM, you have to look for macrosomia. That is why your abdominal circumference, if that is more than 75th percentile, more and more intensive, better glycemic control is required. For your delivery, for labor, high rates of preterm can be there, spontaneous abortion can be there because of the preeclampsia, and LSES or even a normal delivery is possible. Just GDM is not an indication for your cesarean section. Neonate, you have to look for hypoglycemia because of the hypertrophy of the beta cell. They can have then hypoglycemia, hypocalcemia, RDS, hyperbilirubinemia, macrosomia. The cutoff is actually 4.5, but here in India, it's what is considered is like 3.5. Postnatal management, breastfeeding is allowed, and ideally insulin is again better because whatever drug, even metformin, is slightly secreted in your breast milk, but that's okay to give. Like that's what we do in clinical practice. Recommendation is to again screen if let's say the patient get reversed post delivery. Again, you have to get an OGTT after 4 to 6 weeks postpartum, and lifestyle management and MNT would be required, especially once the patient weans off. You have to counsel the patient for weight loss, otherwise the patient will turn into over type 2 diabetes. So lifetime, yearly, annual screening is what is recommended by the guidelines. And if the patient is planning for again pregnancy, preconceptional care is required because these patients may have again diabetes in the second pregnancy or third pregnancy, whatever it is. Diabetes management in elderly. So let us talk about now the elderly. So elderly are slightly different, their requirements are different. So let's start what I would not be discussing. So I would not be discussing any type 1 elderly. I would not be discussing regarding the complication. I would not be discussing regarding DK, HHS, which is common in elderly, because it's just a 45-minute session and we have to cover too much of here. So what are we discussing? We are discussing the special needs, special attention required for the elderly because they may have frequent hypo unawareness can be there. They may not be monitoring. They may be living alone. They may have tremors, so they may not be able to prick themselves. They may not be able to inject insulin. It may be difficult for them to have a rotation dial. They may not be able to see properly. They may have altered sleep-wake cycle. They may be on polytherapy. They may have BPH, polyuria, UTI. All those things are happening with elderly. Bone health, osteoporosis is something which has been addressed in the recent 2 3 years in all the guidelines. So again, ADA has totally emphasized on this. So that is something which you should be screening in elderly population, especially somebody having diabetes for more than 10 years. You should be screening for osteoporosis. Again, not going into details too much here, but the T score, what is required for treatment for diabetic is different. It's not 2.5, it is 2. Okay, because the microarchitecture is altered in diabetes. Then the elderly can have cognition issues, polypharmacy I would be discussing, and then the physical disability, again, max challenge. This is something which you should be understanding. This is not from ADA, this is from Diabetes Canada, and I thought this is really important to discuss with you. So frailty assessment is what should be done in your elderly patient. Elderly, that means somewhere more than age of 65 70. There are different guidelines for that, but it's not obviously 50s. Okay, so frailty assessment is, you can see here 9 frailty scale. So 1 to 3 is fit, well, managing well. It is like they are aged just by numbers, but physiologically, biologically, they are okay. So keep their target as you would keep for any other. Whereas mildly frail and moderately frail, that is your category 5 and 6, this is somewhere where the patient will require assistance for their work. Vulnerable is between these two, whereas severely frail, very severely frail and terminally ill, this is something very very important to address, and they are totally different from your routine patient, and this needs to be addressed. So let us talk in detail here. So cognitive dysfunction can be there with your patients, and they may be taking wrong OHA, they may be forgetting to take OHA, or they may be doubling their doses. They forget that they have already taken the medicine, again they are taking. So all those things happen in elderly, which you should be seeing and addressing. Self-management task would be slightly difficult, especially at a higher age, and new knowledge acquaintment and skill learning would be difficult for them. So try to keep the regime very very simple. The combination drug may help here, will reduce the pill burden, will improve the adherence, and they may not forget reminder, keeping a reminder on the phone that they have to take this medicine. All those are done. Then there are pill box, and very important is to make caregiver understand about the disease. They should be knowing about the medication, the effects, the side effects, so that they can help the elderly patient. They may have physical disability with their routine activity. They may have hearing loss. So whatever you are telling, they may not be able to understand because they are not able to hear only. They may have vision impairment. They may not be able to see the medication name. They may not be able to see what is their sugar. They may not be able to see how much insulin they are injecting. So what they can see is like they can count the clicks because that's noisy, right? They may have decreased mobility. They may not able to inject themselves insulin with single hand, right? So again, that's a problem. They may have falls or the fear of falls. So again, they should be looked for that, and do not give something which is very sedative, right? So all those neuropathic medication, that should be given with caution. And then they are non-earning, so they are dependent financially on their kids, so that should be again taken into consideration. uh, Affordability is something which needs to be taken into consideration, especially in India, before prescribing, because here the insurance sector is not that strong. Also, insurance doesn't cover most of the time OPD treatment. Now let's talk about the glycemic targets. So glycemic targets, if you see the guideline, this is from the ADA 2025. If you talk about elderly with something having limited life expectancy, who is frail, the target is 8. Up to 8 is okay, we are okay. But if you can achieve a lesser HbA1c without significant hypoglycemia, then you should target it lower. So that is the guideline. But as I've told you regarding the frailty assessment, so this will again depend where the patient will fall. If the patient is functionally independent, if the patient falls in 1 2 3 category, the frailty index is between 1 to 3, you target as low as like your normal patient, right? Whereas patient is frail, you can target a slightly higher HbA1c, that is okay. And if somebody is in the end of life, somebody having a terminal illness, say a metastatic disease, where the life expectancy is very very limited, so your target is not targeting any HbA1c. What is your target is that you should be avoiding hypos, more importantly, and then you should be avoiding any hyper also, which may lead to DKA or HHS. Somewhere even sugars up to 250 also is allowed. Patient eating some sweet is okay. That's because you are not preventing any long term complication. Even with that sugar, the time required for him to develop complication is much longer, whatever time he is having, because he's already terminally ill. So he'll not have that time that he'll develop the long term complication of diabetes. So we don't have any much targets here for your pre and post meal, and the targets are different depending on the frailty index. So in general, somebody frail, you relax the target. Somebody functionally independent, you keep a strict target. That's the basic concept here. Similarly, for the TIR, if you talk about, in general, time in range is kept more than 70, and the range target is like 70 to 180, and then level 1, level 2, all those things, you know. But for the elderly population, somebody who is frail, somebody having multiple comorbidities. You don't want him to land up into hypoglycemia, because that can be an end of life, right? The patient may fall, the patient can develop fracture, the patient can develop any arrhythmia, all those can happen. The patient can develop some cardiac event. So that is what you don't want, right? So you want your hypos to be lesser. So here TBR, that is time below range, should be less than 1%. So you are compromising in your time in range just to reduce your TBR, so that you are allowing your TAR, that is time above range, to be slightly higher. Okay, this is higher. Okay, so if your TIR is more than 50%, we are okay. But what is more important is your time below range. That should not be more than 1%. So you can allow your above range up to 50. That is okay. And pregnancy, we have already discussed. The patient can have higher risk of hypo because of renal insufficiency, autonomic neuropathy, cognitive impairment, hepatic dysfunction, and then the therapy with sulfonylurea, sedative agent. Maybe the patient is also consuming alcohol, and polypharmacy is again very important. There can be some drug which can alter the metabolism of our OHS. And then some of the OHA, you have to be cautious, especially like pioglitazone. If the patient is already having osteoporosis, you should not be prescribing them. If the patient is having NYHA class 3, class 4 heart failure, you should not be giving them. SGLT2, if the patient is having recurrent UTI, BPH, you should not be prescribing until unless there is very hardcore indication for SGLT2. Then sulfonylurea, you should be prescribing which lesser hypoglycemia, which are short acting, or you may avoid sulfonylurea. Metformin, again, EGFR is very, very important. So you have to reduce the dose. If EGFR is less than 50, less than 30, you should not be prescribing. 30 to 50 at a lower dose is what is recommended. Insulin, if you're prescribing, you have to look into visual acuity. You have to give very simple regimen which the patient can follow. And then dexterity, you have to look into that whether the patient can inject themselves or not, right? Monitoring glucometer, which do not require coding, which are large, easy to hold, bold numbering, so that the patient can see. And those meters which has memory or link with your mobile, that is preferred. And then CGM would be preferred in this type, where the patients can see their sugars without pricking, and you can see even nighttime nocturnal hypoglycemia. Now, the last part of today's session is diabetes management in hospitalized patient. Again, a very important topic here. So why are we discussing? See, because if the patient is having poor control during hospitalization, the patient can develop acute complication like your DK, or the patient can develop HHS, and then wound healing is impaired because of uncontrolled sugar. Infection risk increases, the length of hospital stay increases, and then survival and overall your outcome decreases, right? So that is impaired with your poor sugars. Now, you can have any of those. Either the patient is already known diabetic on treatment, the patient can be known diabetic and not taking treatment. The patient can be undiagnosed diabetic, first time diagnosed during your hospitalization, or it can be just stress induced hyperglycemia, the patient who is not diabetic, but at present the sugars are going higher, or because you have given some drug, especially steroid, that is why the sugars are going up, right? So any of those can be there. So you have to see what you're dealing with. Let us discuss few of them. So if the sugars are higher and your HbA1c is also high, probably you are dealing with a pre-existing diabetes which is not diagnosed. Whereas if the HbA1c is okay and sugars are higher, probably you are dealing with stress hyperglycemia or drug-induced hyperglycemia. Now let us talk about targets. So what to target? So if the patient is having more than 140 of the sugars, 140 mg per dl of blood glucose, then if HbA1c is not available with you for past 3 months, a recent one within 3 months, you have to get again an HbA1c. That is what the ADA 2025 guidelines recommends. Coming to targets, the target is 140 to 180. This is the recent guideline. Earlier guideline also says a more stringent, and they have given their numbers, like you can go up to 110, 100 also, if you are doing that without significant hypoglycemia. That is again very important. For non-critically ill patient, the target are 100 to 180, so a wider range. But for critically ill, 140 is to 180 is what you should be targeting. Now, whether you should switch everybody who is on OHA to insulin, whether you should give a combination, whether you should continue OHA, that is a very important question for admitted patient. What should I do? So let us discuss this. So the guideline recommends that if anybody critically ill, I am talking about critically ill patient, having blood sugar more than 180, which you see at least two times with 24 hours apart, if you are seeing these two readings, you should be treating them. You should be initiating insulin in critically ill, I am talking about. For non-critically ill, you can either prescribe a OHA or insulin. That is what the guideline says. But again, it will depend on patient to patient. It will depend on for why he is admitted, right? In non-critically ill also. So that you have to see. So insulin indication, especially IV, if somebody is having DK, HHS, critically ill, not taking NPO, somebody who is in intra-op, peri-op, because the critically ill, if let's say the BP is lower, your subcute insulin may not be absorbed. The perfusion may change. Somebody who is on pressor agent, the insulin, whatever you are giving, the PKPD of the insulin would change. And then there is indication severe hyperkalemia. Irrespective of your blood sugar, you may be giving your insulin just to treat hyperkalemia. Vice versa, somebody having hypokalemia, potassium of less than 3.3 or 3.5, you should not be initiating insulin. Whatever the blood sugar are, even the blood sugar are say 400, you should not be initiating insulin. Reason being, it can even worsen your hypokalemia and the patient can have arrhythmia, right? So insulin is recommended for most of our patient in admission, especially if the patient is critically ill. You should be prescribing IV insulin. Non-critically ill, the patient can be on subcute insulin. You can give OHA if the patient is admitted for say a minor procedure like endoscopy or say cataract, something like that. Then you can prescribe OHA. Now let's talk about the protocol, how to give IV insulin, how to make IV insulin. So that is what we are going to discuss. So there are n number of protocols. Some of them I have labeled here, the Portland, Lewin, Yale, Cup, Gans, all those. But it's not important to know each and every protocol. In fact, nobody in the world can remember all the protocols. So what is more important is to create your own thing where you would have your own institutional protocol. That and that is to be implemented by your staff, and your staff should be trained for that. And depending on your resources, depending on how better your staff can do, you should devise your own protocol. So the exact protocol is not that important, and institutional adaptation of these protocol is what is required. So let us discuss how we do it. So first, let's discuss regarding the infusion, how to make a insulin infusion. So what you do is you take 50 ml of normal saline, and then you add 50 unit of short acting. Very important is short acting insulin. Never use a long acting insulin for your IV preparation. I'm talking over here about IV preparation, okay, intravenous. So that can be given either by an infusion pump, or if you don't have that facility, you can use a dial set where you can dial and you can use what rate the infusion is given, right? The target, as we have already discussed, it should be between 140 to 180. All the short-acting insulin are approved, regular, Aspart, Glulicin, Lispro, and your newer insulin. All those are there. See, difference between regular insulin and analog is that they have slightly tweaked the amino acid so that what happens, the PKPD of the drug changes. That whenever you are giving it subcutaneously, but when you are giving IV, the half life remains same whether you give a regular insulin or you give an analog. So analog would cost almost double triple of your regular, so better is to use regular. You will get the same results. The receptors are same, right? So you'll get the same result. Initial 15 to 20 ml of the solution should be flushed of this 50 plus 50. Reason being, because insulin will bind to the tubing, and once it is saturated, you can use it. So some 15 to 20 ml you have to discard, you have to flush through the tubing. And then depending on what is the blood sugar, you have to start the infusion. So a bolus can be given, may be given, may not be given, again a institutional protocol. So somewhere around 30, more than that is there, maybe you can give a priming bolus, but even if you don't give, that's okay. Infusion you can start by current blood glucose upon 100. Let us say the sugars are 400, you start with 4 units, or let's say per hour, 4 units per hour. And let us say it is 200, usually it's not like 200, it's above only for IV most of our patients. So that is how you give it. Okay, now this again you can take a pick. It's slightly difficult to remember. A easier way is, see, whenever the blood sugars are very high, say 500, 600, your glucometer will not give the reading. So what is important is to get a venous blood glucose, so that you know what are you dealing with, because then only you would be knowing the rate of fall. So somewhere around 50 is okay for us. So let us say the blood sugars were 800 at the beginning. After 1 hour it is 750, 730, we are okay. We don't want it to be normal within an hour, because then you are increasing the risk of cerebral edema. So fall of some 30 to 50, irrespective of your blood glucose level, you are okay. Do not change, do not increase the infusion rate. You cannot increase, like let's say the sugars were 800, now it is after 1 hour it is 700. No, I'll increase that, the blood sugars are not controlled. No, you continue, it is falling, we are okay with that. So no change is required if the blood sugars are higher. And when the blood sugars are within the target range, if the blood sugars are falling by more than 50, you have to reduce it by 50%. And if they are falling by more than 25, you have to reduce by 25. That is how you would remember. Okay. And then if the sugars are going even lower, you have to reduce it by 50%. So that is how you do it. Okay. This is a Chinese proverb here. I hear, I forget, I see, I remember, I do, I understand. मैंने सुना, मैं भूल गया, मैंने देखा, मुझे याद रहा, मैंने करके देखा, मैं समझ गया. So same way for this, until unless you do it, you will not be able to understand. You cannot replicate just by reading. Okay, so you have to do it. Then only you will be able to understand how we are adjusting all those things. Now, once the patient is very stable and sugars are stable for 4 to 6, the patient is out of decay, no acidosis, no ketone, especially the blood ketone. Urine ketone can be positive, that's okay. And hemodynamically stable patient can be switched from IV to subcute, but very important is overlapping. So you should not be just stopping your IV insulin, because the half life is just 2 to 3 minutes. That's it. So once you stop your IV insulin, the blood sugar will keep on increasing. So overlapping is what is important. What you do is either you calculate how much insulin you have given in your last 24 hours, that is your TDD, or just your 6 hours and then you multiply by 4 hours, that will again make it 24 hours. And then from that total daily dose, 80% is what you will start, 80% of the calculated total daily dose of insulin TDD, and 50% you will give as basal and 50% you will give as bolus. So that is what should be done. Sliding scale and correctional dose are two things which needs to be discussed. Sliding scale is outdated, should not be given. It's a reactive approach. It's non-physiological and the patient keeps on going hypos and hyper. That's not recommended. So let us say the blood sugars in the morning fasting is 100, and according to sliding scale, you don't give insulin. The patient has taken now breakfast, the sugars goes like say 300. Now you have given insulin 6, 8 units, something, whatever you have written. The sugars crashes to 80, 70, something like that. The patient is feeling hypoglycemia. Then you have given some sweet, something like that. The sugar goes to 300 again. So this keeps on happening. So that is not to be done. Correctional doses you can give. Let us say you have prescribed somebody as glargine, you have to take 10 unit, and you have prescribed a regular insulin, say 6 units. So here what happens that even on normal glucose values, that is say 100, the patient will take 8 unit, so sugar will not increase. So one regime is prescribed, and over that the correction doses are prescribed. Okay, so if the sugars are say in the fasting 250. So sliding scale will also say you have to give insulin. This correctional dose will also say you have to give insulin 8 plus something correction you have to give. So that's the basic difference between the correctional dose and the sliding scale. Sliding scale is not to be given. Basal bolus is what to be given, plus the correctional dose should be mentioned, so that at that point of time the sugars are controlled. Because see, what the patient is eating, how much the sugar is there, depending on that the dose will keep on changing. There cannot be a fixed protocol, okay, take this much only. So you have to address that. Okay, now let us discuss in hospitalized patient. If the patient is on tube feeding, enteral feeding, so enteral feeding, it's a continuous infusion. Insulin is what is required. Sometimes in TPN bag people do mix insulin, but that's not a very good thing to do because the dose adjustment becomes difficult. Tube feeding, again basal bolus is what is recommended, or some too early, for early, you can also give a short acting insulin. Both are okay, because depending on how much tube feeding is given to the patient, you do a RT spread, again you see how much to give. So that is how you do. So there, whatever the sugar and whatever you are feeding, depending on that the insulin should be given. Then somebody who is on steroid in hospital, depending on which type of steroid, how much dose, frequency, duration, the doses of insulin should be changed. Especially somebody on prednisolone, NPH works very good because the PKPD of NPH matches with the blood sugar increase of prednisolone. So whenever you give in, say before breakfast, the sugars in pre dinner or post lunch is what is the highest on those patients who are taking this prednisolone. So NPH works there very good. But somebody on dexamethasone, a basal insulin or a basal bolus is what would be preferred. Peri-op, again, you have to initiate insulin if the blood sugars are more than 180. You target again the same thing what you have done in IPD. And then depending on the surgery indication of the surgery, you have to keep the targets, whether you can initiate OHA or not, depending on that would be decided. And take these patients right early in the morning so they don't go into starvation ketosis. If the patient is NBM, you can give a GKI drip. Okay, that's glucose potassium infusion can be given. 2 weeks of good control is okay for a minor procedure, but for a very big procedure, a better glycemic control would be required, especially if the procedure is elective. If you don't want to go very urgently, you can wait. That would be what is recommended. Metformin, usually 1 to 2 days you have to stop. SGLT some 3 days, okay, but again depending on what you're doing. For a cataract surgery, it's not recommended that you change everything. For a very minor procedure, you don't want like tooth extraction, you don't want everything to be stopped, right? So depending on what surgery, what the gravity of that surgery, you have to change the OHA. For insulin, a dose reduction of 20%, 30% is good enough, but again monitor sugar and you have to adjust the insulin. NPO or sick patient not eating anything, GKI infusion is what is required. Blood sugar more than 180, insulin is what is required. No sliding scale, absolutely no for a sliding scale. Patient eating perioperatively, post-operatively, you can give a basal bolus. Patient not eating, you have to give a neutralizing drip infusion. That is what is recommended. On discharge, if the patient is requiring a larger dose of insulin, basal bolus would be preferred. Somebody with a very minor surgery eating well, you can switch to OHs. Again, it depends on what the patient is undergone, right? So I think we have finished within 45 minutes. So we can take the question. You can keep this number also. If you have some doubt, I've kept the barcode also here. You can scan it. You can ask now. You can ask later on. Both is okay. So I'll just stop sharing the screen.
Thank you so much, sir, for your presentation. We have a few questions that have come during the session. I'll just take them up one by one. Uh, the question is asked by Dr. Bora. In dialysis patients, how should insulin be timed on dialysis days versus the non dialysis days?
Okay. So again, it will depend on the basic regimen. See, some of the patients on the, like those who are on dialysis may require a very less unit of insulin. They are okay like that only because the circulation time of the insulin increases. The excretion of the insulin actually is not there in the CKD. So that is why they are on very low dose of insulin. So there you can give a very low dose, you can continue. But if the patient is not eating at all, like in sometimes it's like that, then you may not, you may skip. But generally the guideline recommends that 25-30% of the insulin should be reduced on the dialysis day. But again, it's a basic guideline, right? Basal insulin you have to reduce some 30% one night prior. But again, that's a guideline, but every patient is different. You have to consider that what is the blood sugar, and accordingly you have to titrate your insulin. There's no fixed regime where you should keep, okay, I'll do this only. It's not like that. You're muted.
Sorry, sir. This is the next question. In cirrhosis with portal hypertension, what considerations guide the choice of anti-diabetic therapy given altered drug metabolism and the risk of lactate acidosis?
Yes, so if you are talking about cirrhosis with portal hypertension, that means what you're talking about is a decompensated CLD, right? So guideline says that in decompensated person, you have to use insulin. That is what is recommended, especially your child book C. But somebody who is having compensated cirrhosis, we do sometimes give them sulfonylurea, short acting sulfonylurea. We do give them, and GLP-1 again for decompensated it's not allowed. A safest option is to give them insulin rather than be on the OHA.
Thank you, sir. We have another question here on cirrhosis. Is what is the role of SGLT2 inhibitors in cirrhosis?
Okay, so again, as I've already mentioned, if you're talking about decompensated, it's not recommended to give any of the OHA. That is what is recommendation. But there are some data that it may benefit in cirrhosis, it may benefit in ascites, but that is not what is done in practicality. But let us say if the patient is having some other indication, like your heart failure, then we do give them drug at a lower dose, that we do give. But in general, just some few studies on ascites reduction, something like that. Otherwise, it's not recommended.
So we have multiple questions on diabetic ketoacidosis. They're similar, so I'll take them all together. Is what is the diagnosis of ketoacidosis and the management in house, and also when a patient is on dialysis?
Yeah, so the DK is again totally different. I can just share an algorithm that would be better. But somebody having more than 250, and yes, with this, one more thing I would like to point out with SGLT2 inhibitor, even you can see euglycemic decay. It's not always you see more than 250. Somebody having acidosis, so that's your DK with ketone positive. Now we have your blood ketone with the lower bicarb. That is how you diagnose. And even you have mix of DK with HSS. So there are a number of things which we can discuss. But the management is very, very essentially maintaining hydration, most importantly, and maintaining your sugars. Once it is somewhere around 200 250, you have to start with again neutralizing dip. Do not start insulin right at the beginning. First, hydration is more important. Look for hypokalemia. Once any patient having a lower potassium should not be initiated IV insulin. Somebody having more than 5.5 of potassium, you can initiate insulin without supplementation. Between 3.5 to 5.5 of potassium, you have to give potassium supplement along with your IV insulin. You have to look for hypophosphatemia, which happens because of the intravascular shifts. So these are some basic things which you should be knowing, but again it's like a 1 hour session in itself.
Yes, sir. Sir, in moving on to the pregnancy questions. In pregnancy, which insulin regimen is preferred?
It's a
Basal
basal
bolus.
bolus. Yeah, it's a basal bolus. Pre-mix, all those are outdated. You should not be giving in pregnancy.
And how to titrate the dose?
So, see again, if I can share the screen, that would be even better way to explain you. But let us discuss if we have time. Some 3 minutes, I'll give. No issues. I'll just share a screen. Otherwise, it
Yeah.
will not be. You will not be able to understand it. Yeah, I think the screen is visible.
Yes, sir. It is.
Yes. So see, dose adjustment of, there are two things. When you talk about the basal bolus, basal is much easier to adjust depending on the fasting sugar. So whenever the fasting sugars are say 140, if you have kept target lesser than, so whenever there is 140 or more, you increase by 2 units. So let us say I have prescribed to one patient as you have to take glargine 20 units, and you have to take regular insulin or any of the new analog. Let us say I have prescribed them 12, 12 and 8 units, something like that I have prescribed them. So they'll check at least 4 times their sugar. That is most important thing. So fasting is required, pre-lunch is required, pre-dinner is required, and post-dinner is required. So that is what it should be done. So depending on fasting, let us say one day the fasting is 200, you have to increase the dose. So there are three regime for basal adjustment. Either you can take average of three, lowest of the three, that is what you can do, and depending on that the basal dose should be adjusted. Now let us say the fasting, you first fix fasting, that's the concept, FFF, first fix fasting. Okay, so that's the concept. So once you have fixed your fasting, let us say it is now 140, 120, anything like that, you have reached. Now when you're talking about your pre-lunch, let us say it has been now 200. So that means whatever insulin you have given here, that was not sufficient, provided the patient has not eaten something great carb on that day. So again you have to monitor few more times, say it was 121, 128, 1 something like that. The fastings are always okay, but PP is always going in the range of 220, 250, 180, something like that. That means whatever insulin you have given here in the breakfast, that is not sufficient. So you have to increase this 12 dose, right? Though the sugars are here okay, here it is increasing, so you have to increase the before breakfast insulin. Similarly you do for your pre dinner, post dinner. And post dinner is important because post dinner should not go below 100 or 120, otherwise the patient will develop nocturnal hypoglycemia. And depending on that time of sugar, let us say the pre lunch is 200 now, so you can add a correctional dose here in the lunch time, but on the next day you increase the pre-breakfast unit so that your pre-lunch does not increase. So that is how it is done. I hope this was clear. This can be learned with practice only.
Yes, sir. Thank you so much. I'm pretty sure the explanation helped. Uh, we have another, we have multiple questions, but I'll just take a few more.
Yeah, we'll end the session in 5 minutes, I would say.
Yes, sir. Uh, in a patient using hybrid closed loop insulin pump, how should the settings be modified during the steroid therapy for asthma?
See, you have just three settings which you can do in a 780G. That's the insulin pump we have available. That is what you are targeting. Your whatever carb you are taking, temp target, and your ratios. More than that, you cannot do anything. So that is the time where the automation takes help itself. Sometimes patient do enter false carb, but that is not what I do recommend.
Okay, uh, so one question here is, a patient with glyphosine complains with genital itching, which may be the best oral hyperglycemic agent to replace it.
Yeah, so see, usually most of the time it's mycotic infection rather than UTI, which goes away with antifungal. Some 5 days therapy is okay for them. And if there is a compelling indication, we do continue SGLT2 inhibitor. If there's no compelling indication, we do stop SGLT2 inhibitor. That's the basic thing, and you can switch to anything. It's not a fixed protocol. There are no such protocols actually.
So I'll take one last question here. Between the DPP4 inhibitors and the SGLT2 inhibitors, which is more suitable for noturia, kidney function, and for the need for heart protection?
So the data is very clear. See now, if you see the guideline after, like, I've done a complete session, it's available on YouTube where we have compared 5 years guideline. You just need to type the ADA update 2025. It would be there. So you see the guideline. If the patient is having already established ASCVD, or if the patient falls in category of high risk, like age more than 55, dyslipidemia, urine microalbumin positive, smoker, there's compelling indication that you should be prescribing an SGLT2 inhibitor or a GLP-1 RA. That's clear cut guideline, right? So obviously you would be prescribing them. Somebody with heart failure, you have to prescribe a SGLT2 inhibitor, whether the patient is diabetic, non-diabetic, diabetic with controlled sugar, diabetic with uncontrolled sugar, whatever it is. You have to prescribe an SGLT2 inhibitor for preserved as well as reduced ejection fraction. It's a clear cut guideline here now.
I think that brings us to the end of this session. If there are any more questions that come across, sir, I will relay them to you
Yeah,
via WhatsApp.
sure,
Thank
sure.
you so much, sir, for joining us today and taking so many questions and teaching us a lot, like nuanced care for special situations.
I hope the session was useful and you will take at least some of the information and imply in your clinical practice.
Yes, sir, definitely. Thank you so much,
Thank
everyone,
you,
for
everyone.
joining.